Hello, everyone. Good evening. Thank you for joining. Uh, we host a webinar series which is Brain Rich, and we host this every 3 months. We're from the Rohini Nilekani Centre for Brain and Mind, which is a collaborative initiative between NCBS and NIMHANS. Our research focuses on understanding severe mental illnesses like bipolar disorder, schizophrenia, dementia, OCD, and addiction through an integrated approach that brings together molecular genetics, genomics, brain imaging, and stem cell technology. So, if you would like to attend more such webinars and talks, please do stay in touch with us. Today we have Professor Allan Young. I'll hand it over to Dr. Biju for a quick introduction.
Hello. So welcome to today's seminar. So our speaker is Professor Allan Young. He's Chair of Academic Psychiatry and Head of Department of Brain Sciences at Imperial College London. He's one of the world's leading researchers who has worked for decades to understand the causes of severe psychiatric illness and develop better treatments. He has held academic appointments at Oxford, Newcastle, the University of British Columbia, King's College London, and is a past president of both the International Society for Affective Disorders and British Association for Psychopharmacology. So, Allan, I welcome you to give the talk.
Thank you very much, and thank you for the kind introduction. I'm just sharing my screen. Can you see my screen and hear me?
Yes.
Okay, good. Thank you very much. And let's just try. So I'm just trying to adjust this so there's less on the screen. Okay. Well, thank you very much, and it's a great pleasure to talk to you. I'm afraid I can't be there in person, but we hope to visit India again next year and try and build research collaborations. And as the kind introduction said, I'm talking about recent advances in depression and depression treatment. These are my disclosures. I'm employed by Imperial College London, although I still have an attachment to King's. I'm a consultant psychiatrist in the UK NHS. I have grant funding from various bodies. And I'm chair of the academic faculty of the Royal College of Psychiatrists, which has about 7,000 members, and vice president of the CIMP. Can you still hear me okay? Yeah. Okay, I'll presume you can.
Good. Yeah.
So just to give an advert for our CIMP conference, I know that some of you are coming to this. This is in Glasgow this year, June 26th to 28th, and look forward to seeing you there. So this is the scale of the problem with psychiatric disorders. This is a nice graph from the Global Burden of Disease study published in The Lancet just before the COVID pandemic. And you can see that mental health problems are in the top 10 causes of disease burden. 125 million disability-adjusted life years worldwide lost in 2019, and this has increased by 50% over the previous 30 years. The big problems are depression, anxiety, and then we have problems like bipolar disorder and schizophrenia. The graph, I think, is very illustrative because it shows that most of these disorders really onset in adolescence and early adult life. And then the burden lessens as you get to later life, particularly 59 to 60 and so on. And that's partly because, unfortunately, our patients die about 10 to 15 years earlier than the general population, partly from suicide, but also from the common killers. And again, the graph shows the breadth is the actual relative contribution of disease burden. You can see depression, anxiety, and related things like bipolar disorder are the biggest part of the problem. Just looking at the UK, we have an adult psychiatric morbidity survey every year. The last one that's been published is the one for 23-24. 20% of adults in the UK have a common mental health problem, again, most commonly anxiety, depression. 24% in women, 15% in men. Anxiety, depression, mixed anxiety, and bipolar disorders was about 2%. This is higher in the young. higher in the poorest areas, but you can see even in the richer areas, it was still 16%. So it's not entirely socioeconomically driven. It's increased in those with physical health problems and unemployment. And the prevalence has really increased in the last 20 years. This is very costly to the economy. So the argument to society in general for expending resources in treating and seeking to understand the causes of these problems is pretty clear in terms of the economic potential benefits. This is a classification of mood disorders. I show this just to emphasize that depression is not all one thing. Depression is, of course, common across all mood disorders, but you can see the major split is into bipolar and depressive disorders, with major depressive episodes occurring across the range of mood disorders. The concept of major depressive episodes have been criticized by Professor Ed Shorter in the British Journal of Psychiatry in 2014. This is an editorial which is well worth reading. Ed Shorter is a historian who works in Toronto, and he points out that major depressive episode criteria really date from Spitzer in 1980 with the introduction of DSM-3. And they include a lot of different syndromes. They include melancholia, they would include atypical depression, so on and so forth. And Ed, I think, makes a point which really points the way to personalized or stratified medicine, that we should be looking within this broad diagnostic concept for subtypes and subsyndromes. Now, a few basic points about depression. Is it a chronic disorder? People like me who work with complex, challenging, and treatment-resistant patients very often think that depression is inevitably going to have a poor outcome, but that's, of course, not true from the epidemiological studies. This is a marvelous study by Eaton from the Archives of General Psychiatry in 2008, a prospective population-based cohort study of 3,481 adults with 23 years of follow-up after their first episode of depression. Now, the striking thing is that 50% had no future episodes over the subsequent 23 years. And that will surprise many psychiatrists, because we see people in the other half who have recurrent or unremitting courses. And of course, the median time to 2 to 3 years was skewed by the unremitting group. If you actually look at the group who have no future episodes, they tended to have episodes that lasted 4 or 5 months. At the moment, we can't really predict who's going to go in the poorer trajectory. Only younger age of onset significantly predicted this, but clearly there's scope for the future in trying to do predictive modeling to identify individuals who are likely to be in the poorer outcome half as early as possible. Now, just to show that this is a meta-analysis showing that this study really agrees with the literature. This is of waitlist controlled trials and observational cohort studies looking at the time to remission and predicted remission in adults recruited from primary care settings with untreated major depression reached about 53% in 12 months. So 50% or so will have a good outcome, even without treatment. Now, there's also a challenge in terms of minimal treatment. This is a paper by Graham Thornycroft from 2017, but we've also published a series of papers from a European Brain Council study that I led about the value of treatment in depression. Despite being a leading cause of disability, only a small number of patients receive minimally adequate treatment, 1 in 5 in high-income countries and less than 4% in low and middle-income countries. And the barriers to treatment will be familiar to you. Scarce mental health services. There are some countries that only may have a small number of psychiatrists. Lack of awareness of MDD as treatable, and of course, stigma and social exclusion. And remember that depression is as well as having a good deal of stigma from other people, it's a self-stigmatizing disorder. Part of the nature of depression is that people often feel unworthy of treatment. So in terms of our current depression treatment options, They fall into three main categories: pharmacological, this is antidepressants and augmentation adjunctive treatments; non-pharmacological, which are a mixed bag from lifestyle changes, psychotherapies, CBT, light therapy, and so on; and neurostimulation, which has in common the fact you stimulate the brain with electricity, but in actual fact has a wide range of possible applications, from things like transcranial direct stimulation that may be applied very early in the treatment pathway, to things like vagus nerve stimulation, which are applied very late in the pathway. Digital therapeutics, to my mind, is not a treatment per se, but rather a platform for delivery of treatment. These are software-based interventions, which can be done via smartphones or computers, a wide variety of different things, from CT delivered by smartphones through to large language models, and there's lots of research going on in this area. It's important to note that unlike wellness apps and tracking devices, digital therapeutics, at least in Europe and the US, are rigorously tested and have to deliver evidence before they're licensed. They're supported by clinical data, independently a combination with medication. Importantly, they may increase access. The scalability is huge. We're finding that vast percentage of our patients have access to the internet and to smartphones, and potentially this could leapfrog over some of the shortages in the provision of therapies. I don't think this is going to really be applied late in the treatment pathway. I think the digital therapeutics are a potential early stage treatment. A number of other points. Patient preference impacts treatment response. This is neglected in research and to some extent in clinical practice. This is work by George Papakostas from Mass General and by Koskis, just showing the effect of preference on response to medication, psychotherapy, or the combination. And I think the one to focus on here is psychotherapy. If you prefer psychotherapy, you have a much, much higher response rate to that than medication, and combination somewhere in the middle. And there's a similar pattern with people following their preferences in the response rates. This is almost never reported in trials. So particularly in trials of psychological therapies, or indeed the new psychedelic treatments, where there's very often a very strong patient preference for the new treatment, this really is a potential confounding effect in terms of evaluating treatment efficacy. And there's also the placebo response. The placebo response is of huge interest, I think, and I think this has been reignited by the psychedelic studies, where essentially even the so-called pseudo-control condition of the low-dose psychedelics will have a considerable placebo response, because the placebo response is likely to be boosted by the psychedelic experience. So you can see there's three components here: the treatment effect, the true placebo effect, which may have a biological component. Some PET scan studies have shown that placebo responders to dopaminergic agents with Parkinson's have increased dopamine release. And then the perceived placebo effect, which can be due to natural fluctuation of disease, spontaneous recovery, and so on and so forth. Okay, in terms of pharmacotherapies for mood disorders, these have been around for a long time. I really date the modern era of treatment to electroconvulsive therapy in the 40s, and then lithium and antidepressants in the 50s and 60s. Now, I think it's clear to say that our current antidepressant treatments are efficacious and acceptable. This is Andrea Cipriani's huge meta-analysis of 21 antidepressant treatments with over 100,000 individuals. And you can see all of the drugs were more efficacious than placebo. And in actual fact, measured by staying in the trials, they were more acceptable, except for clomipramine, than placebo as well. And indeed, agomelatine and fluoxetine were more acceptable. What we've added to this recently is augmentation treatments. I just want to mention pramipexole. This is a paper that my group participated on, led by Mike Browning from Oxford. Pramipexole is a dopaminergic agent used in Parkinson's, and Mike and colleagues did augmentation of antidepressants in the acute treatment-resistant unipolar depression, and it had robust efficacy with an effect size of about 0.6. Now, it's a relatively small trial, and N of 80 to 100 in each group, and it wouldn't get a license for this, but I think it's reasonable on the basis of this to use it in clinical practice, and it's likely to get into the treatment guidelines. So I'd urge you to have a look at that paper. But the scale of the challenge remains. There's a high variability in treatment response. There's only 35% full remission after initial antidepressant treatment, whether it's whatever modality, whether it's neurostimulation or drugs or therapy, and 30% develop treatment resistance. Factors involved in this include genetics and neurobiology, comorbid physical conditions, social determinants, cultural and personal preferences. And of course, remember, early life trauma is one of the large factors, the big contributing factors that's been identified. And we're very much interested in researching this to poor treatment outcome. And of course, this leads to problems with inconsistent findings between studies and small effect sizes. So one size is unlikely to fit all, a bit like Ed Shorter said. So I want to talk about some of the new developments and treatments. Ketamine and S-ketamine are often thought of as very new treatments for depression, and they're often thought of as originating for this use in the United States. But in actual fact, the first study that we've been able to identify comes from Iran, published in the 1970s, which used ketamine as an abreactive agent. This is a very, very interesting study. As far as we're aware, it's the first psychiatric investigation of ketamine. They looked at ketamine like the way we look at psychedelics these days, looking at the effects in the round and looking at the mind-expanding effects. And interestingly, they used a dose range that's pretty similar to what we find today. Interestingly, and this wasn't a randomized controlled trial, but rather a patient treatment cohort, they found effects on depression and particularly anxiety, and that's being mirrored by what's been found more recently. So there's lots of work on ketamine and S-ketamine, and myself and Roger McIntyre and others synthesized this in the available evidence, and that's there as a reference text. But I want to just highlight our more recent New England Journal of Medicine paper, where we did a phase 4 study, myself, Andreas Reif, and others, and where we looked at S-ketamine compared to quetiapine for treatment-resistant depression. Now, this is interesting. The headline result is that S-ketamine had a bigger effect, but quetiapine did quite well. But look at the time course. The acute phase treatment was over 8 weeks. There was a continued accrued benefit right out to 8 weeks. But this also continued out to 32 weeks. Now, there's a real-world evidence study, which hasn't been published yet, but I've seen the data, looking at individuals treated with S-ketamine. And if they respond well to S-ketamine, it seems as though about 50% can discontinue successfully from the S-ketamine, or they'll stay on the antidepressant after 6 months of wellness. That data will be scrutinized a bit more in the publication process, but that does mean that the criticism that if you respond to S-ketamine, you'll need to stay on it forever doesn't really pertain. We did some work looking at the mechanism of ketamine's rapid onset antidepressant effect. There's a whole variety of potential pharmacological mechanisms, but we particularly focused on the opioid receptor contribution. This was because of work from the US, really from Alan Schatzberg and colleagues. This is, I think, Nolan Williams' first author paper, where part of the treatment effect of ketamine was blocked by the opioid receptor antagonist naltrexone. Very, very small numbers, an N of 7. But they followed up with a slightly larger number of 12 and found an effect. So this was really something that was very contentious in the US, I think because of the fears of abuse. of both ketamine, S-ketamine, but also because of the opioid epidemic, which is killing over 100,000 people a year in the United States from overdoses of drugs such as fentanyl. So my colleague Luke Jellin, supervised by myself and Professor Mittal Mehta, my colleague in London, did the GOMARK study. And this was really Luke's work and was published in Nature Medicine in September last year. And this really followed up from the William Schatzberg work. We found that naltrexone pre-treatment compared to placebo pre-treatment attenuated both the ketamine-induced glutamate activity as measured by brain imaging, and also significantly attenuated clinician-rated symptoms of depression. So this was a randomized crossover study. So the imagers talk about the glutamate surge that happens after ketamine. Naltrexone attenuated the so-called glutamate surge, the glutamate-glutamine increase relative to N-acetylspartate during ketamine infusion, and you can see the statistics there, and also at the same time attenuated the reduction in Montgomery-Åsberg Depression Rating Scale scores. So this is quite neat. This is not only showing a reduction in the antidepressant effect, but a parallel reduction in the brain imaging, the likely brain substrate of the antidepressant effect. And here's some of Luke's data from the paper, and you can see the MADRS total and the daily change as shown there. So this doesn't abolish the ketamine antidepressant effect, but it shows there's a component of it which is due to the opiate receptor, which is blocked by naltrexone. Okay, I want to talk about psychedelic psychiatry, and this is a picture of myself in a room which I thought looked psychedelics, but just to say it's not me actually under the influence of psychedelics. Psychedelics have, of course, been around since the dawn of recorded human history. They've been used in religious and magical ceremonies, but they have a relatively more recent role in medical science. Now, this is a brief history of medical psychedelic therapy. You can see the first identification in 1899, and then various work looking at mescaline and so on. But really things took off with the discovery by Hoffman in Switzerland of LSD. This was used widely, and other psychedelics were used very widely in psychotherapy in the 50s and 60s across the world. They seem to be used in two different ways. They seem to be used in what's called a psycholytic way with really quite low dose. Now, this isn't microdose. This would be a low dose, but enough to have a noticeable effect by the participant, the patient or the participant. And this is a bit like the Iranian ketamine paper. It was a way of almost abreacting the patient and facilitating psychotherapy. And of course, higher doses give a full-blown psychedelic experience. This became part of the culture wars in the 1960s between Richard Nixon and the hippies in America. And it was essentially, psychedelics were essentially banned. And if you look back at the literature of the time, and James Rucker and I have summarized all the trials, despite pretty good evidence of benefit and very limited evidence of harms, the US FDA banned this, and the ban was followed worldwide. So these became really classified in a way similar to heroin or other serious drugs of abuse. The Renaissance was really led by a group in Baltimore and Johns Hopkins, and by my colleague in London, Professor David Nutt. The initial studies were in end-of-life depression, and there's a real argument for using rapid treatment in early life depression. And then David Nutt and David Arizzo and others have really pioneered the way for treatments, for studies in treatment-resistant depression. And my former boss and mentor, Professor Guy Goodwin, has, of course, masterminded lots of these with the company Compass. So this is Guy's big paper. This is single-dose psilocybin for treatment-resistant episode of major depression. You can see myself and loads of others are on this. This is another New England Journal of Medicine paper. And here's the headline results. So you can see there's no placebo, but there's a pseudo-placebo dose of 1 milligram, an intermediate dose of 10 milligrams, and then the full dose of 25. And the single dose, high dose of 25 significantly reduced depression scores compared to the control dose after 3 weeks. Same effects weren't really there with the low dose of 10 and 1. All those groups were associated with adverse effects. And this was reasonably powered with 233 patients. Now, other work that we published with Guy has shown that the antidepressant effect was really correlated with the psychedelic experience and not with any parameter related to patient therapy. So this is a bit of a bone of contention in the field. Some individuals feel that it's really all about the therapy, but in actual fact, I think a correct reading of the data to date is that the therapy is important for safety. It's important for integration of the experience, but it's not the major contributor to benefit per se. Guy has followed this up, and a number of phase 3 studies have been done, including a study versus pure placebo and studies that are similar to this. These results have been announced in a press conference, but we haven't seen the detailed data. But Guy is going to present it at the CIMP in Glasgow. So that's another reason for you all to come to Glasgow. In short, we know that there's a significant benefit above placebo or low dose of about 3.8 MADRS points. So that's respectable. It's not bigger than the effect that you would see with some of our other strategies, for example, pramipexole. But remember, this is a one-off dose, and we see that from the graph here, at least with this data set, that the people that respond seem to maintain the response for 12 weeks. Now, there's a huge number of studies going on in the psychedelic field at the moment, and I've got a slide here just summarizing some of them from Robin Carhart-Harris, who was in Imperial but has gone to San Francisco, early study, right through to David Arizzo's study in Nature Medicine, which was published very recently. And you can see the effect sizes are pretty large. David's study with DMT is very interesting because this is a much shorter acting medication than psilocybin. Of course, the great disadvantage of LSD is that it's very long-acting. And you can see the effect sizes look impressive, but remember, these are likely to be inflated in part, I think, by two things: patient preference and a potential placebo contribution. So this is David Arizzo's very recent paper published in Nature Medicine this year. A short-acting psychedelic intervention, and you can see this was a robust effect of DMT. Interestingly, I think half-life pharmacokinetics are very important here. LSD lasts for days. Psilocybin, the sessions that we do can last up to 10 hours. But this DMT study, you can see that the effects were really evident quickly, and the effect of the drug wears off. The psychedelic experience wears off within an hour or two. So this is much, much more likely to be practicable and scalable to the clinic. And there's other ways of delivery. So this is DMT delivered in a vaporized form. This is a phase 2 clinical study by Carvello and colleagues, and there's another group has just done a similar study, which is not yet published. And you can see that the time to response is really, really very quick indeed. And then the antidepressant effect continues, but the psychedelic effects wear off, as I've said, in well under 2 hours. Okay, so that's the psychedelics. I want to talk about next stage physical treatment options here and talk a little bit about neuromodulation and neurostimulation. So there's three of the main treatments that we use here, and I think they all occupy a slightly different role in the treatment pathway. We've done studies on transcranial direct current stimulation, and there's limited evidence of this in resistant patients, but what we call partial responders, and that's people who have not responded fully to the first treatment, or people indeed who haven't been treated, TDCS seems to be very efficacious, and I'll show you one of our published trials that shows this. I actually first became interested in this about 20 years ago, working with the Parkinson's group, and of course, TDCS is used in Parkinson's and has been shown to ameliorate depressive symptoms there. We then moved to repetitive transcranial magnetic stimulation, or RTMS, and there's the famous Stanford protocol that Nolan Williams, who tragically died recently, pioneered. This is probably, in my view, further down the treatment pathway for treatment-resistant depression rather than partial response, as TDCS would be. We certainly, in my part of the NHS, have a clinic supplying this, and we have reasonably good response, but I don't think it's as beneficial as ECT. ECT, and I showed the graph a few minutes ago that showed it introduced in the 40s. I think ECT still has a very valuable role. I don't think it's clear that ketamine or any of the other treatments have made ECT redundant. Can be used first line in psychotic depression or catatonia, but should be used for treatment resistance and is very, very effective. So just to show you, this is a paper I did with Cindy Fu, my colleague in the Maudsley Hospital, again published in Nature Medicine. So this was the Empower pivotal phase 2 study for TDCS on depression, which showed a 58% remission in 10 weeks. But remember, these were not patients who were fully treatment resistant in the terms of having failed 2 serial antidepressant treatments. Typically, they'd failed 1 or none. And TDCS can be given at home. The patients can actually buy it themselves. It's now FDA and EMEA approved. And I think this is a very reasonable option for treating depression early in the treatment pathway. In terms of next step physical treatments, there is deep brain stimulation. This was pioneered by Helen Mayberg in Toronto in the United States. She worked in both. This has implanted electrodes in the brain and is, of course, used to treat Parkinson's and other neurodegenerative disorders. It is also used, there's some work going on in psychiatry to treat opiate addiction and also OCD. And I think the data in those 2 indications are more promising. But in treatment-resistant depression, 2 trials run by Helen Mayberg failed. And I don't think this is something that we would be recommending. We did a trial in the UK as well, and it again failed. I don't think we'd be recommending this as part of our treatment armamentarium unless we get further data. Ablative neurosurgery, this is really something which has really essentially fallen out of treatment altogether. It's very rare for us to treat anyone in the UK with this. There is the option, however, of doing magnetic resonance guided ultrasound, which is non-invasive, as a way of substituting for ablative neurosurgery. This has already been done in Parkinson's, and our clinic in London with the neurologist does this. This essentially uses MR guided ultrasound to target particular centers in the brain related to tremor, and it's got a good evidence for helping tremor in Parkinson's. And there's a possibility, I think, of resurrecting this as a technique to substitute for ablative neurosurgery. And we're also doing some studies of this or planning some studies in opiate addiction with Professor Anne Lingford Hughes and her group in my department. But I want to talk mostly about vagus nerve stimulation. Now, vagus nerve stimulation is commonly used to treat epilepsy. In the UK and across Europe, there's hundreds or more patients with treatment-resistant efficacy who have been treated with this successfully. It was applied to treatment-resistant depression. This came about because of observations from the epilepsy literature that patients who were depressed and epileptic, when their epilepsy responded, they also seemed to show benefit for depression. And my neurosurgical colleagues very interestingly say, even if people aren't depressed, they show enhanced well-being. So there's benefits on positive affect. Now, the initial trials in the United States failed, and I'll show you some data about that, really because they were too short-term. All the patients who had the implant continued to have it and went on a registry, and as time went by, the efficacy became evident. So I think this does have a role in very treatment-resistant depression. I think it's a tragedy if someone who might benefit from vagus nerve stimulation dies by suicide or reaches the end of the treatment pathway with not having the option, this option presented to them. In London, we possibly do up to half a dozen a year, but I think there's more patients could be benefiting from this. So this is the data from Scott Aronson from the United States. And you can see over follow-up out to 5 years, VNS plus treatment as usual did much better than treatment as usual. But early on, the significance didn't show, really because the trajectory of recovery was quite slow. And really, I think you need to follow people up for 1 or probably 2 years before you can really capture the full benefit. And you can see from Scott's paper that the cumulative response rate at 5 years was 40%, just under 41% for treatment as usual. But for VNS plus treatment as usual, it was 67.6%. So really quite a big effect. Now, we have followed up everyone in Europe who's been implanted with the Lenova device. And there is, across the whole of Europe, quite a number of patients. So we're up to quite a few hundred, mostly from Germany, a few from the UK and other countries. And in actual fact, the 1-year data is actually even more positive than the US data published by Scott. So I was at a meeting with other mood disorders experts in the UK, most of whom didn't have experience of VNS and who were really very critical of it. Psychiatrists often find it easiest to be critical of things that they don't really know about. But in actual fact, I think, and my colleague, Professor Hamish McAllister-Williams in Newcastle, is a great proponent of this, that this has a very limited but potentially very valuable place in the treatment pathway. So to summarize, there's a variety of approaches for achieving remission beyond initial treatment currently available. Practicing psychiatrists know about all of these: increasing or switching antidepressants, combining antidepressants in novel ways, augmentation, and I've talked about augmentation with pramipexole, which I think is a very valuable potential treatment strategy, and other physical options. There's things I haven't mentioned that we've studied, including probiotics effects on the microbiome. We recently published a study with mindfulness-based CBT, which in the Lancet Psychiatry, which showed really quite significant benefits in treatment-resistant depression. But I think all of these are essentially empirically driven. But I think we may be facing a step change. And this is the reason for the title of my talk. This is looking at the Beacon study, and Bijou knows all about this. This is a study that we're doing in the UK. I'm doing with Professor Paul Elliott from Public Health in Imperial, and Tanya Gergel, Professor Tanya Gergel, an expert in lived experience research from Imperial College London. Beacon is looking at early assessment and clinical onward navigation of people with common mental disorders. So it combines 4 large real-world cohorts with ongoing longitudinal follow-up reflecting diverse populations and healthcare settings. And it's a way of predictively modeling the outcome. So we have the clinical practice data link in the UK, which has tens of millions of people in it, and we've identified 75,000 cases with people with bipolar disorder. Paul Elliott's REACT, real-time analysis of community treatment study, which started in COVID, but now has a number of different follow-up points. And we've identified 17,000 people with bipolar from this. Our Future Health, which is the successor to the UK Biobank, and we've identified 11,000 patients, and we have a smallish cohort, Airwaves, which allows us to look at omics, which is 50,000 police officers and staff. And here's what we're planning to do in Beacon. Look at sequential event histories, look at trajectory deviation, look at data-driven course patterns. This matters because relapse sits within a wider course. Single events don't show the pattern, as you saw from the Eaton study I showed you earlier on, and trajectories show progress after diagnosis, and it makes follow-up potentially more targeted and useful. Now, Beacon is focused on people who develop bipolar disorder, but we will, I certainly am planning with Paul Elliott and my colleagues to look at people that would develop other trajectories, particularly treatment resistance. And here's what we do. In terms of the data analytics, there's risk prediction, trajectory modeling, and then looking at pathways and mechanism. And of course, lived experience headed by Tanya is key to everything that we do. And we hope to get a signal with risk band, course pattern, change over time, suggested review window. And hopefully this will really go to the next generation in terms of how we look at these disorders. And rather than being empirically driven studies, we might be able to specifically target groups that predictive modeling shows might benefit from early intervention. So I'll finish just by quoting the great Bob Dylan. In terms of treatment of mood disorders, I think it's true our old road is rapidly aging. I think there's a new one coming. I think we're all going to have to lend our hand. And I think we can anticipate over the next few years that the science underpinning the treatment of mood disorders will be rapidly changing, both from the introduction of new types of therapy with everything from neurostimulation, digital platforms, and psychedelics and forms of ketamine, through to the type of predictive modeling that I've just described in our Wellcome funded study. Thank you very much for your attention, and I'd be happy to take questions. Did you hear me?
Yes, Alan.
Yes.
Okay, so I think thank you very much for the talk, and let's look at the chat box for questions. So I think I will request people to switch off their videos, please, and we will. Kadambari, I think we will take questions and we will discuss, right?
Yes, we'll take the questions from the chat box now, and as people have them, they can drop any more
Yeah,
questions.
so they can keep asking questions. So maybe I'll add in a question of my own as more questions keep coming. So Alan, what do you think about stratifying patients in terms of different types of treatments? What are the various ways in which you may want to do that, or maybe you're already doing that?
Well, we already do that to some extent. So, for example, with psychotic depression, we would go straight to ECT, or we would use combination of full dose antipsychotics and antidepressants. And if they were catatonic, we'd go straight to ECT and so on and so forth. But I think that's not satisfactory enough. We need to be able to look at individuals and tailor and personalize the medication much better. And that's what's happened in other medical fields like oncology and so on and so forth. So the reason I like to show the Eaton study is because for that 50% that have one episode and don't get ill again, everything else, anything would work. I mean, you could treat them with, showing them Marx Brothers movies or whatever, and they would get better because they were going to get better anyway. So I think we need to think about refining our populations a bit more, not just having a catch-all of a major depressive episode, but looking at age of onset, number of episodes, and then looking at subcharacteristics. But really, this will require a lot of science to really advance it, a bit like's been done in oncology over the past 30 years. If you go to an oncology clinic for one of the common cancers in my hospital, you know, they can, for example, say that, first of all, they'll offer you the chance to be in a trial, which is not that common in psychiatry. And then they will say, well, if we add this treatment, there's a, you know, likelihood that your 5-year survival will be increased by 7% and your 10-year survival by 5%. That really is the overall model in terms of doing research that we want to follow.
Yes, thank you. We will discuss this further. So now let me have a look at the chat box. So there are some questions. So I'll just read out some of them. So one of them is, what is your perspective on plant-based molecules and phytochemicals as potential antidotes?
Yeah, absolutely. I mean, we've got lots of plant-based molecules which have made it into our pharmacopoeia, everything from digoxin to aspirin and so on and so forth. And I think there's probably a world of potentially useful medications in there. I don't think you necessarily need to extract them and synthesize them. It may well be that the mixture of whatever is what's important. But I think it needs to be researched in the same way as everything else. And you need to understand there needs to be quality control. So you've got, you know, you're giving the same thing every time. And then there needs to be ascertainment of potentially benefits and harms. So, so I'd really encourage that. And I think if we focused on that, we might, especially if we looked at the plant-based molecules where there is a belief that they help certain syndromes, we should take that at face value and investigate that with modern science.
Yep. Okay. So the next question is about medical marijuana, and what are your thoughts, especially for depression?
Well, this has really been quite contentious in the UK and in some other countries. There seems to be a cultural belief that marijuana is helpful, and medical marijuana is given everywhere except paradoxically in Canada, because in Canada cannabis is totally legalized, and therefore you don't need to have the medical indications. I think there probably is some benefit for things like pain. There may be a benefit for chemotherapy-induced nausea. I'm really unconvinced about benefits on mood and anxiety and psychotic disorders. And I'm certainly convinced that there's harm. So, for example, Professor Marta De Forti, my colleague in the Maudsley, has shown pretty clearly with Robin Murray, her husband, that the stronger forms of cannabis with higher THC levels are very much related to psychosis, and possibly as much as 20% or so of first episode psychoses in London are actually linked to cannabis. There was a belief that you could mitigate this with CBD, and we've certainly been involved in this, and Professor Philip Maguire is leading a big trial. The problem is that CBD tends to have low bioavailability. So I think, and there are some legal cases brewing in the States against the providers of medical marijuana from the families of young people who've committed suicide or gone psychotic. So I think the evidence is pretty shaky. But of course, there's this deeply held belief in some societies, for example, in North America, that cannabis self-evidently is a good thing for your mental health, and I certainly don't see that as being clear-cut in terms of the evidence.
Yep. Okay, so there is a question about ketamine and RTMS. So the question is, if they are effective, why are they still less recommended and used in psychiatric hospitals?
That's very interesting. I mean, I think I think it differs in different countries. I mean, I think we see in certainly the United States ketamine clinics, which are often run by anesthesiologists with master's levels psychologists and nurses with no psychiatric input, where people can drop in and get ketamine. And we, of course, all remember the tragic case of Matthew Perry, who was being treated with ketamine and also getting it illicitly. In the UK, we have a number of centres that give different forms of ketamine. And S-ketamine, and my hospital is one of the few that actually allows S-ketamine in the UK NHS. But these are really reserved for treatment-resistant cases. And our clinic, for example, run by Professor Sophia Papa in West London, offers both rTMS and S-ketamine. Now, this is not widespread throughout the UK and in many other countries, and I think that's really because there is a lack of adoption of efficacious new treatments for psychiatric disorders. And this is something that we're very concerned about, that we'll be seeing data come out of, for example, new treatments that are available in the US and other places, but simply the health service providers in the UK NHS and NICE and so on won't fund it. So I think partly this is a political problem, partly it's the profession sometimes being overly conservative and so on. But we need to say, why don't our patients deserve the new best treatments, really, and campaign on that line.
Yep. Okay. This is a bit of a repeat, but I thought it'd be nice to, focus on that again. So there is a question on psychedelic assisted psychotherapy and your views. You did mention this a little, but maybe you can detail that a little bit. I think probably it's about psychedelic assisted versus just psychedelics.
Yeah, sure. I mean, this is something where the people hold very strong opinions in the evidence, in the absence of evidence. I think if you look back at the 1950s, there seemed to be low-dose psychedelics given with psychotherapy, and that's why I quite like the Iran paper with ketamine and used it in an abreactive way. I certainly think there's credibility that approach might be helpful, but there's not really been enough trials to help us evaluate that properly. The use of that's in Guy's Compass trial and David Aritzo's trials are quite different in my view. That's giving a full-blown psychedelic experience. And then the psychotherapy comes in two forms, with preparing people for the experience, with ensuring safety during the experience, but also helping them integrate thereafter. I think there's going to be very fertile work, or very fertile area for research with a potential combination of psychedelics and psychotherapies. So, for example, I was speaking to Professor Thorsten Barnhofer yesterday, my colleague, actually Thursday I was speaking to him, from Surrey, who did the MB-CBT trial. And we really wonder about people that respond to psychedelics, then offering them a course of mindfulness-based cognitive therapy as a way of maintaining the response. So I think there's going to be very interesting research coming out of this area, and we need to apply the same scrutiny to all different modalities. We need to be we need to value benefits and harms in both the psychotherapies, the drug treatments, and also the combination, and get over partisanship where we really have a preference for benefit from one type of treatment, and somehow that's what comes out in the trials.
Okay, we'll take two more questions and then I think it will be time. So I think there is a question on how people attempted to do a combination of ECT and rTMS simultaneously and in treatment-resistant depression.
Yeah, I think there's a couple of trials with that I've seen, and they're not given absolutely simultaneously, but they're given during the same treatment course, and there seem to be enhanced extra benefit. But I think would want to see bigger trials just to make sure. I mean, I think it's great if people are looking at these potential combinations. I'm not sure that the original Stanford protocol, which was really very intensive RTMS, which was done by Nolan, who, as I said, tragically died by suicide not so long ago. I'm not sure that's fully been verified in subsequent treatments, but I think the ECT RTMS combined package during a treatment course is a very interesting thing for further examination. Yes.
So the last question. Do you think many of these techniques that you mentioned will work for chronic dysthymia, or do you think that will be different?
Yeah, I would hope so. I mean, I personally think that we need to think about returning our patients to full wellness, and I think chronic dysthymia is very often a consequence of previous depression where the person hasn't fully recovered and they get stuck in a very chronic depressive position. Interestingly, Glyn Lewis, I think, did some studies with antidepressants in what you might think of as a dysthymic population, people who still had some degree of low-grade symptoms of depression, and they were quite effective. So I think we really need to think really in terms of treatment outcomes clinically about what we would like for ourselves or our loved ones. I mean, we'd really like to return to full health. And I think chronic dysthymia is not full health. It's very corrosive for the person's life and function in society. And I think there's more studies to be done there.
Thank you very much. I will give it back to the organizers, Kadambari.
Thank you, Bijou, and see you soon.
Yes.
Thanks.
Thank you. Thanks, Prof Allan. Thank you, everyone, for joining us today. I have just pasted some links in the chat box. Please do fill our feedback form and follow us on social media. Thanks again for joining today.
Okay. Thank you. Bye.
Bye.